Hey everybody, it's Leila, Health Education Manager here at AI Arthritis, and I am excited to come back to you today for round 3 of our EULAR 2024 Go With Us program. And so today I'm going to be talking about exercise, which has been talked about a little bit already, but I have a little bit more details to give you all, and then also a little bit about fatigue and the new recommendations from EULAR. And so I am going to start out with the exercise sessions. So there was a one big session, but there was 4 different speakers in one session. The session was called Moving on Solid Ground, Testing Physical Performance. The first speaker talked about inflammation in RA and the effects of it with physical activity, basically saying that there's insufficient evidence to conclude that physical activity can affect inflammation in diseases like RA. There isn't enough information to say that it's not beneficial or that it is beneficial. These small sample sizes that they do have, it does say that both combined aerobic exercise with strength training exercise did reveal that there was changes, but it was only for 6 people. And so they can't necessarily say that it is sufficient evidence to conclude that inflammation decreases, but it did happen for some people. They do talk about as well this DOMS, which is delayed onset of muscle soreness, and that happens to a lot of people that are new to exercising or haven't exercised in a long time. And a lot of people can mistake this for disease activity, thinking that the exercise that they're doing is bringing them into a flare, but it actually is just a reaction to soreness. And so it's delayed onset of muscle soreness, so it may happen 72 hours after you exercise. And it is, like I said before, recommended to do both combined strength training and cardiovascular training. So things like high intensity interval training can be very beneficial for those with our diseases, because that combines strength training with cardiovascular training. Okay, so on to the next session. High interval training is what I was talking about. This speaker spoke about a study that they did with RA patients, and they basically had a study where they did a 16-week program using interval-based aerobic training plus resistance training and dietary changes, and the goal was to improve cardiometabolic risk and decrease disease activity. And what she was saying basically does verify what the speaker before was saying, that a combined cardiovascular and strength training exercise regimen is the most effective for people with our diseases. It also helps the function of the innate immune system and T cells that are all big players in our disease. The next speaker talked about pain and how pain is affected by exercise and how exercise can help improve quality of life in general. And they did an analysis of a bunch of different studies, 381 studies to be exact. And in what they found from the findings of those studies is that pain with regular exercise decreases a good amount. It is seen that from patient-reported outcomes that pain does decrease with regular exercise. There had been no side effects of symptom exacerbation in disease. The exercise, as long as it is prescribed to that individual and is basically made off of what they are capable of, they did not see any exacerbation in disease or any increased disease activity or any increased pain. And on top of the actual physical pain part, they talk about how just in general, the endorphins from exercising really helps to increase quality of life, along with serotonin, which is another happy hormone that we have. Exercise helps to release serotonin and endorphins. So the last section of this exercise session was specifically on ways to measure cardiac output in exercise and how increasing cardiac exercise can help with overall health with our diseases. And the measurement test that they're using is called CPET, which also stands for Cardiopulmonary Exercise Test. And it is a pretty common test that happens. They put on all these different nodes on you and you do exercise, and they test all of your different levels with your oxygen and an ECG and things like that. And from these measurements, they are basically able to see how the level of risk of cardiovascular disease is and basically be able to see how to lower it. Because with the measurements that they get, you can see where you need to tailor the prescription for exercise. And they're basically saying that for rheumatology purposes, that this CPET measurement can help when coming to exercise tolerance and really getting that individualized prescription for exercise. And overall, this was an amazing session, just talking about exercise and all of the benefits. And I personally, over the past year, have really seen all of these benefits of exercise. For the past 10 years, I had been very sedentary, not working out, feeling like, oh, I'm in so much pain, I really can't. But last year I did get weight loss surgery, which did help to propel me into my exercise journey. I really just jumped into exercise this year in February, and it has made a load of a difference when it comes to both joint pain and fatigue. The only joint pain that I do feel now that I'm working out on a regular basis is in my hands, and that's where my worst joint pain is. But for the rest of my body, my back, my hips, my shoulders, it has not hurt as much as it used to. Lastly, I saw the session about fatigue and the recommendations for fatigue. Unfortunately, overall, there was not much to report back on that's new. They did have new overarching principles and new recommendations when it comes to fatigue, basically saying that there aren't many options out there and it's not being talked about enough in the rheumatology setting and in office when it comes to patients and doctors talking about different ways to combat fatigue. And there are ways to help with fatigue, but there's so many different ways that someone experiences fatigue and so many reasons why someone can experience fatigue that has been very hard to do studies. They do want to do more when it comes to patient-reported outcomes and just learning more about how affects patients so that they can design more studies to see what's going on and how they can bring more interventions for fatigue. But basically just encouraging all of the different healthcare professionals to have those conversations with their patients. And they have seen that some pharmacological medications do help with fatigue, but they are not prescribed for fatigue, only for high levels of disease activity. But what they did say is that disease activity does not necessarily correlate to the amount of fatigue someone has. Someone can have very low disease activity or even be in remission and still experience fatigue. And that in itself is what makes it very hard for them to study and to give actual recommendations on. That was the 2 topics that I wanted to talk about today, and I'll be back tomorrow with another debrief.